Okay, so we are ready for our third session that is going to be on policy and health economics. And it's my pleasure to introduce our moderator, Tanya Bubella. And Tanya will be coordinating or moderating this panel. She brings a lot of experience on the IP and GELS area. So Tanya, thanks a lot for moderating.
Thanks, Catalina. Thanks for the invitation, and welcome everybody to the afternoon session. So we'll try to keep this perky and alive so that no one falls asleep after lunch. At least it's not Italy where they serve wine at lunch. So it's my great pleasure, while I choke, to introduce my fellow countrywoman, Robyn Ward. Her bio is in your documentation.
Thank you very much, and I really appreciate the chance to be here. I'm sorry I'm sort of slightly jet lagged, as I only arrived yesterday morning, so as I said yesterday, I'm not sure what's going to come out of my mouth, but hopefully it's something to do with the talk. So what I thought I'd do is try and go through basically three sections. Firstly, I wanted to describe a little bit about the Australian context in genomics, where the investments are occurring, then just briefly touch on Australian healthcare system, which is where genomics needs to fit into, and then final slides will just be around a particular case study of assessing the genomics technology in the context of picking it up into the healthcare system and some unexpected findings from that particular analysis. So I'd like to start with this slide, which is, I think we all hope that genomics is going to have some really great results for healthcare. But at the back of our minds, and with the skepticism that comes from, I think, practicing medicine from a lot of years, you're always aware of the downsides of some of these things. And that's something that obviously we need to take into account in thinking about genomics. So the way Australia has approached the investment in genomics was firstly to set up alliances, very much along the lines of the approach that has been taken in Canada. We have a national alliance called the Australian Genomics Health Alliance, and then two main state alliances. Some of the states have other states have put investment into genomics, but not necessarily set it up using the alliance model. So there's a Queensland Genomics Alliance, a Melbourne Genomics Alliance in Victoria, a New South Wales state investment, but not set up in the same way as the other three alliances in genomics. And all have really been set up along very similar lines, and I'll just show those on the next slide. On this next slide, I'll just show you how they all fit together. So if we're thinking about the sort of roles of each of the sectors in research right through to clinical practice, we're envisaging that research institutes, universities take the role in discovery research. The Australian Genomics Alliance is supposed to be sort of picking up the discoveries from the universities and research institutes and then working out how to apply them in the healthcare system. The Queensland and Melbourne, which is like your province alliances, are supposed to pick up what happens in the Australian Genomics Alliance and move that further down the chain. And then it's supposed to get into clinical practice, and why I put a hard line there is because there is another big gap about there's not a smooth changeover between what's happening in the state-based alliances and really taking it to the final step of getting it into healthcare. So the whole aim of these alliances is to sort of overcome fragmentation and siloing, change clinical practice and make sure genomics is incorporated, create the evidence base to support genomics in a long-term basis, and enable research and future adoption into practice. So that's the sort of mantra of all of the alliances. The Australian alliances have really connected with lots of the healthcare providers across the country. They've also heavily engaged in the research sector. And although this slide looks very busy, I think it does show the genuine interest and connection across Australia in genomics. And many individuals within these various institutions have really bought in to the concept of being part of this alliance. I must say it's much more about individuals than institutions. So individuals have played a role, but I wouldn't put my hand on my heart and say the healthcare providers in these institutions as an institution have really bought in, although they're very permissive around allowing their clinicians to engage in the alliance work. So now, where I was up to a few moments ago was just to show you how the alliances are structured. Essentially, they've all run along this model of setting up these cross-cutting programs or enabling capacities, whether that's in research, diagnostic networks, the data approaches, economics and health policy, and then workforce. And we've heard about that today as similar models have been talked about already. And then running across those have been these flagships or demonstration projects, which are really designed to pick up on each of the four cross-cutting themes and show how you could actually implement something in clinical practice, whether it's in the cancer, in rare diseases, infectious diseases. Each of the alliances have picked up different flagships or demonstration projects, they're called in some of the alliances, all with the aim of sort of making the case, collecting the evidence, showing how you can connect up the cross-cutting themes into an ecosystem. I know someone didn't like that word yesterday, I can't remember who it was, but an ecosystem anyway that brings all these things together. One of the biggest learnings has been around data, and that has been a really big focus for all the alliances. The data challenges are enormous, and I think in many ways people thought that genomics was going to be the driver for and the solution for all of the data problems that exist in a healthcare system. All the clinical data, all the things that haven't been solved for the last 25 or 30 years in Australia healthcare's system for managing data were going to be solved by getting genomics to solve it. And I think in the last year or so, it's been realised that that's probably not such a smart idea. Genomics can't solve the data problems of the country. So I think that's been a lesson learned. I'm just mentioning, this is the only slide I have on Indigenous and people in Australia that Catalina just asked me to mention what we were doing here. You know, that area hasn't been heavily invested in. There is a Australian National University, which set up a National Centre for Indigenous Genomics, and they've done a lot of work working with the Indigenous community about, really I'd say about profile raising and education around what genomics means, rather than necessarily getting into some of the more complex issues around data and storage and so many things. So they've done a lot of good work, but they've got a lot of work ahead of them as well. So there was this big investment in the alliances that happened through research investment, and then the government in November 2017 decided to release a framework document, which is called the National Health Genomics Policy Framework. It was endorsed by all of your provinces and Commonwealth, so the state and Commonwealth endorsed it in November, and the strategic priorities and principles are written there, and nothing that's written on that slide hasn't already been spoken about today, about person-centred care, getting the workforce right, financing it, services, data again, and then the principles that should underpin the framework. Now the framework didn't come with any money, it was just really a statement of intent and strategy and principles. It didn't actually push for an investment, it just sort of said this is where the country stands on this particular issue. It was developed through about over a year of consultation with the community, so it did indeed, I think, reflect something that was very genuine. And then on the 17th of May, that's our health minister, in case anyone didn't recognise him, he decided to make an investment of $500 million in genomics in a budget announcement. And that was going to be, he didn't actually put any constraints around how that money should be spent, it didn't have a plan, but after he announced the $500 million, the next week he announced a 13-member steering committee, which would need to come up with how that was going to be spent. And sitting on that committee along with others, interestingly with not much more about that than what I'm putting here on this slide. He wants better health outcomes for patients, he wants faster diagnoses, targeted treatment for health outcomes, but he kept emphasising, and it's very clear, that these funds are for research. He did also announce the first funding stream from that investment in a project called Mackenzie's Mission, which he allocated $20 million from the $500 million, and that's a project around screening for rare diseases in children. So the Minister is very convinced, like many in the room, I suppose, that genomics will be basically the lever to bend this healthcare cost curve, and that we've been spending way out of proportion to what we can afford, and that genomics will be the solution to that. And I won't dwell on that slide, but I guess this is the concern. There's a lot of money going in, and maybe not the thinking around how it should be best invested at the moment. And as I think we touched on in the last section, a lot of this investment is going into research with very hard lines, at least in our government, that it can't be used for routine care. So huge investment in research, they want it translated into clinical care, but we're not allowed to use any of the money for clinical care. And so we've got sort of first world research, third world routine care. We don't really have third world routine care, but that's the sort of nature of the paradox. As I said, another 500 million into research, but can't be used for routine care. So it's a little bit confusing trying to work out how that should function in practice. So in Australia, if we turn now to routine care, this is funded by taxpayers. We have a federated model with overlapping healthcare responsibilities between states and Commonwealth, a mixed private-public model where patients can pay if they choose to do so, but most of the care that is really needed for serious illnesses are funded publicly. And the reimbursement of healthcare really comes from, at a Commonwealth level, comes from two buckets. One to fund drugs, which is about 13.4 billion a year, and another that comes for everything that isn't a drug, and that's about 22 billion a year now. And the committees that advise the government on whether they should spend are listed under there. One's called PBAC and the other one's called MSAC. And in order to get something onto that list, then they need to go, then an application needs to go through this process, which involves evidence assessment, actual a case made, both an economic case as well as a clinical case made for investment. And this applies whether the technology is a disruptive technology or it's a routine technology like getting MRIs of the knees, for instance. And so that HTA process is something that Australia is very committed to. Publicly, our ministers say that they accept that every technology needs to go through this, whether it's disruptive or an accepted technology. It needs to happen at the point of investment, and it needs to happen for the benefit of the population, ensuring equitable access to healthcare, and that we get value-based pricing. So that's the paradigm in which the taxpayers pay for healthcare in Australia. But at the same time as we've got that going on, we know that we've got an escalating cost of healthcare in Australia, a lot of waste happening at the moment, and a lot of that waste is happening through multiple services for the same person over and over again. And I think when we think about genomics moving from a product-based service into a service-based, that your sold service, a package of things, not just a product, then our propensity to overuse services, whether they're connected to products or not, is something that is of concern. And how we deal with this issue of waste in the healthcare system is a real challenge in Australia, and I'm sure here as well. Wherever we have a new technology, then we typically see an expansion in use, not a contraction in use. So we haven't had anything yet come into Australia that really has bent the cost curve. Everything has been expansionary. And this happens through a number of ways. Some is the expanded definitions of disease through by diagnostic tests, more use of tests, and then more use of treatment. And these things are constituted into a couple of groups. Overdiagnosis, where you end up over-testing. And I mean, if you've got genomics at the back of your mind, this is also going to be susceptible to this. Over-testing, over-interpretation, and then a consequence is over-treatment. And this is how waste gets generated currently in the healthcare system in Australia. And just to show you, I won't talk about the slide on the left, or the graph on the left, which is attention deficit hyperactivity disorder, where our use of drugs for that particular condition has just gone up. You can see the blue line, how fast that's rising. But on the right, if you just look at diabetes, where you change the definition of diabetes, you can end up with at least 1 million more Americans being diagnosed with diabetes. And this shifting definition of when you call someone diseased or not diseased then has a whole lot of consequences which ultimately can lead to waste in the healthcare system. And this is an expert group that get together, and I know there's some endocrinologists in the audience, and I'm an oncologist, so I'm no authority on diabetes. But you can see that you can shift where you call someone diseased and not diseased, and then you end up with a whole lot of expenditure after that. So now for the last 5 minutes, I just want to talk about a particularly sobering issue that we had to deal with just very recently. And this is a gene expression test for breast cancer. It's called MammaPrint. You'll know there's a lot of others, Oncotype DX and others. And the idea here is very compelling, that you can test someone who is ostensibly at very high risk of recurrence of breast cancer in the adjuvant setting. This is in the setting that someone's had a curative resection and then thinking about having chemotherapy. And we would class them in the high-risk group. And then by using MammaPrint, we would move their risk from high risk down to low risk. Obviously, some would still stay in the high-risk group, so thereby avoiding chemotherapy. And that just seems like such an amazing thing to do. So, of course, why wouldn't this be an exciting technology? And the company who developed MammaPrint actually did a randomised controlled study on this that was published. And that may have been the beginning of the downfall of this. So in UNETA published the analysis of that study in 2018, and what they concluded in that report was it hasn't been demonstrated that outcomes are improved by withholding adjuvant chemotherapy based on the results of this gene expression test, that non-inferiority in terms of overall survival and all the other surrogate outcomes were not shown, and the results do not rule out the possibility of clinically relevant increase in distant metastases and hence risk of death. And the quality of evidence for the 10-year overall survival endpoint was rated as very low to very low. So that was the UNETA report. It came out in February 2018. March 2018, it was only 1 month later, we were in the midst of actually doing the same assessment for MammaPrint independently. And we came to exactly the same conclusion. For high clinical risk, low genomic risk, randomised to chemotherapy or not, the hazard ratios for every outcome favoured chemotherapy. Hazard ratio was 0.6. For clinically risk low, high genomic risk, there was very little confidence in any health benefit at all. And there was low confidence that MammaPrint was equivalent, but more confidence that MammaPrint was inferior to standard treatment. And so just to show you that graphically, when we look at, inferior, superior, inferior, if you look at the left side at treatment based on just a standard clinical pathological assessment, and on the right side on MammaPrint, and what we concluded here is that inferiority was likely, inferiority wasn't shown. So this test introduced for a very compelling reason was likely leading to an inferior outcome. Absolute terms, about 3% inferior outcome. And if you look at chemotherapy or the new treatments we introduced for breast cancer in order to improve survival, we are very excited when it's a 3% improvement. So this is a 3% decrement. So these are the ways we can manage things coming into the health system. We can do this at this point where new services are introduced. But once they're introduced, it becomes very hard to control this. And I think this MammaPrint example has really brought home to us some of the issues around adoption of genomics and adoption of things without appropriate evidence. There was certainly, with the MammaPrint example, a lot of direct-to-consumer pushing of the test, and a lot of people were paying $4,000 or $6,000 a pop for the test. There were a lot of clinicians who were actually pushing patients to have this test and pay for it out of their own pocket, because it hadn't been through review yet. And now we see these results, and then an independent committee coming up, or group coming up with exactly the same conclusions. We now have a messaging issue related to the clinicians themselves who have been pushing this, the patients who have prematurely adopted it, and what does that mean in terms of how they then view how they've been treated in the healthcare system. So I think this has been a lesson to us around adoption. The other thing that has brought home to us was that this particular conclusion was drawn from a very good study. So a very good study was done and allowed that conclusion to be drawn. Now, unfortunately, it wasn't to the benefit of the people who developed the technology. But I think one of the problems here is if we prematurely adopt tests or drugs at a point where the evidence is not there and people are discouraged from actually getting the correct evidence, you can see that there can be repercussions for that. So I think it's a sobering lesson, and we also don't want to be sending the message that people who do good studies should be discouraged. It's better to do a lousy study, because then you can just use the marketing machine to push it over the line. So it's a very nuanced message. We haven't yet developed the communication plan with the community and with clinicians around this particular evaluation. So I guess I would like to just leave it there with those thoughts, and happy to discuss it later in the session. Oh, that was another cartoon. This is about unintended consequences of policy. So thank you very much.
Fabulous, thank you. I feel your pain. We did the same kinds of analyses in Alberta, trying to switch from Oncotype DX to Prosigna in the breast cancer space. And there's a lot of advantage for companies to be the first mover in a system, because de-implementing things once they've been implemented is a higher hurdle than implementing them in the first place. So making switches is complicated. So first panelist is Mohsen Sadatsafavi, who is on home turf from the Faculty of Pharmaceutical Sciences here at UBC.
Hello, everybody. Welcome to our faculty. My name is Mohsen Sadatsafavi, and I'm a health economist with this faculty. What I'm going to present is actually a reflection of being 4 years involved as a PI health economist in one of the Genome Canada biomarker discovery grant. I am also on another active grant from Genome Canada. This is my disclosure slide. I receive salary support from CIH and Michael Smith Foundation. Otherwise, I don't perceive any other conflict of interest. So this is a distilled version of the most important lesson or lessons that I have learned. 4 years of rigorous interaction with the biomarker discovery team. This is simplified, but nonetheless, to me, realistic aspects of technology development in health. It used to be very linear, from the discovery department to the validation department to the marketing and implementation and so on. What I am going to pitch for, and what I have been trying to do, and I will do so more rigorously in the future opportunities, is a little bit of a time travel. As a health economist, as decision scientists, we can envision what will happen in the future to the best of our abilities when we want to implement technologies and feeding it back to the design stage. That's the gist of my talk today. I think it was in line with some of the complaints that we heard in the morning about all this technology making to the implementation phase and then falling flat on their face. I think there is an opportunity to make the process in its entirety more efficient. So I'm going to jump right to this center. I assume there are people in the room who have been developing biomarkers around into genomics, and I know the currency in communicating science about the biomarker performance is this little curve, the receiver operating characteristics, or ROC. I know people who do these type of work love the ROC. It is really the currency in the field. And I have observed, and people like me have observed in similar activities, that it has been used very heavily to drive the science. 2 examples that come to my mind. At early stage of a biomarker development, you want to decide on the complexity of your marker. How many genes are going to go into the panel, how many SNPs, how many assays, and so on. And the more complex biomarker, the more concave the ROC curve would be, the more discriminatory power it's going to have. But of course, with complexity comes, say, higher cost, more difficulty in implementing, more turnaround time, and so on. The other very typical example is even when you choose the composition of your biomarker, at some point down the road, you are forced to decide on the positivity rule, where to put the cutoff to say a test is positive versus negative. You might want to go for a specific test, you might want to go for a sensitive test, you might want to compromise in between, depending on the clinical context that you are working on. And I have seen the main metric driving this decision is area under the curve, or AUC is purely statistical. People talk about, say, 0.05 improvement in AUC is significant and we should go for it. And of course, from a perspective of a person like me, it is quite agnostic of the cost side of things. Same here, I have seen people deciding on, okay, this is a screening test, we better be sensitive, or the consequence of a false positive is grave, better be specific, and so on. Yet still, again, in my discipline, as much as deciding on these factors, being a biological, clinical, and statistical problem, they are social sciences problems too, because they are associated with resource implications. In fact, the key opinion leaders in the field consider lack of decision analytic approach to decision on these fronts to be a woefully neglected component of the research design. So this is well understood, and this is what I saw in my involvement in a large Genome Canada grant, and it was the biggest lesson that I learned. And again, this is my message to you. Let's bring economics and social sciences in general into the early aspect of market development. So as a health economist, the involvement of a person like me, what can it do with your project? So we can interact with you at different steps. At preliminary phase, we can do a so-called return on investment analysis for you, the estimation of the socioeconomic benefit to the jurisdiction that is funding you. I know Genome Canada grants actually require that, so sometimes we are imposed on you to do that, but it really brings a value down the road. At early phase of biomarker development, we can do literally objective back-of-envelope calculations to show you what parameters of the biomarker is going to be efficient down the road when it comes to implementation time. We can calculate a metric called net benefit, and at earlier stages, it's difficult to come up with cost value because we don't know the parameters exactly, we don't know what will be the market penetration, so we can go with something purely clinical, such as what is the target number needed to treat. The clinician expert in your team can decide on, and again, we can do the calculation for you. At mid-phase, we launch economic evaluation of candidate biomarkers. That will be a full-scale economic evaluation. We give you the metric called ICER, incremental cost-effectiveness ratio. We also launch another activity that my colleague Dean would talk about. We help you see how parameters of your biomarker should be tweaked to maximize its implementation in the community down the road. And at late phase, we can do full-scale economic evaluation, budget impact analysis, pricing analysis, and so on. So I'm going to give you an example of what we did. This was prior to the biomarker grant getting funded. We developed the COPD model, and we could show that among different interventions, the one that has the best return on investment is predictive test for exacerbations of COPD, the chronic lung disease. So actually, the grant was strongly written around biomarkers in this component. That's an example of an early phase. Toward the later phase, again, this is another example of how we communicate our discipline around the ROC curve. We develop decision analytic models, kind of designed that my colleague Sterling will talk about it. We do preference studies so that we can find the so-called sweet spot on the ROC curve for you, in which when you put the threshold, it will be a sweet spot between patient acceptability, care provider acceptability, and economic evaluation. So my conclusion is, don't think of just biology and clinical and statistics. Think of the social science side of things. And don't worry, as economists, we will not always complain about the budget constraint and dollars. We also bring clinical utility in clinically relevant terms. And again, I want to conclude that bringing an early decision perspective to your biomarker evaluation would have a lot of benefit on the road for your project, for the society, for the funding agency. Thank you.
Thank you, Mohsen. So the next health economist up, we have three health economists on the panel, is Stirling Bryan, who's at UBC School of Population and Public Health.
Great, thank you very much, and thank you for the invitation to speak. You can never have too many health economists on the program, is my sort of line. but maybe I'm wrong, so you need to be the judge of that. So I'm going to just give a few reflections on the genomics revolution from an economist's perspective, building on what Mohsen has said. I don't have any actual potential conflicts, I don't think. I am a co-PI on one of the recent LSAP, Genome Canada and Genome UBC grants that I'll talk a little bit about. Paul Keown is the nominated principal investigator on that. And that is actually following a similar approach to the approach that Mohsen described. So this is a project that's looking at kidney transplantation and using genomics to help the matching of donors and recipients so that we can avoid rejection of the organ. So that's the approach that's being taken. There's obviously work happening to ensure that we can actually do that matching effectively. And then what we're doing from a social science point of view is building a simulation model. So we're actually building a model of kidney transplantation in Canada, and we want to understand what the current system looks like and how it operates. And we're going to use that model as a way of then predicting what the impact of improvements in matching of kidney donor and recipients might look like, so that we can actually guide and advise on the genomics work in terms of like what is it that we need to see in terms of performance for this to be a realistic option, what do we need to see in terms of price for this to be a realistic option as something that the healthcare system might want to adopt. So that's the approach that we're taking, and I would applaud Genome BC in particular and Genome Canada for actually ensuring and insisting upon the involvement of people with a legal background, people with an ethics background in that sort of work. So economists start with a negative. So I'm a guy who's always got the glass half full, but my starting point in my discipline is scarcity. So it's acknowledging resource scarcity as a reality. So I would beg you not to put your head in the sand. Scarcity exists, let's acknowledge scarcity and let's respond to that by ensuring that the technologies that we develop actually are going to deliver real value and can be afforded and integrated effectively into the healthcare system. We've got folks who have had responsibility and probably still do for running healthcare systems. I spend part of my time working with those folks. Like, let's acknowledge that they have a really tough task, and we shouldn't be making that task tougher. We should be making it easier. So I think health economists have got something I think health economists have been responsible in part for feeding this addiction to the adoption of new technology. And I think we need to resist that, and we need to have this search for efficiency. And I think a modeling approach. So this is the pathway model that Mohsen and colleagues, and I've been involved in this project, have developed. It's for COPD. We're going to develop a model that's for kidney transplantation. And I see this as like a centerpiece of the work that we should be doing when we're thinking about new technology, existing technology, and bringing technology out of the system. So what I want to talk about is resource stewardship, just in the last couple of minutes. So this is a concept I think that is just like, we all need to embrace resource stewardship. And what we mean by the resource stewardship is acknowledging scarcity. So I think it's a responsibility that we all have. We can't deny the fact that resources are limited. We should respond positively to that, and we should all embrace that. So we should openly acknowledge that. And I think the pathway modeling, the modeling process, can actually be a way for us all to engage in trying to improve the care that's being delivered and the outcomes for patients. So what I would say that we should be trying to bring all stakeholders together around this pathway modeling process, as we're going to be, as Mohsen has done with COPD, and as we're going to be doing with kidney transplantation. We want to listen to everyone who has something to say in terms of how this model should be built and what the reality is of living life with a condition, what the reality is of bringing technology to the table from an industry perspective, the clinical perspectives as well. And I think one of the key things that this says is who should actually be taking the lead here in terms of driving innovation and change in the system. And I would argue that it should be all of those stakeholders. And I would put a particular emphasis on those people with lived experience. So patients, we want to listen much more effectively to the voices of patients in driving improvement and innovation in our healthcare system, but with that resource stewardship approach. We've got an envelope of dollars that we have available. Let's use those to the best effect. And that could be about introducing new technology. It could be about withdrawing technology and releasing funding so that we can actually do better for other patients within our healthcare system. And I'll just, as a final thing, just point you to an initiative, Choosing Wisely, I think is an initiative hopefully most people have heard of. Has anyone not heard of Choosing Wisely? If you raise your hand if you've not heard of Choosing Wisely. Please look up Choosing Wisely. So this is a fabulous initiative that's basically looking at this issue of waste in our healthcare system and the waste that we need to extract from our healthcare system in order to allow us to do other things, like money that can actually be well spent. Like, why do we accept? Some people argue that there's 30% of our spend on healthcare is actually not producing any benefit. We need to extract that waste in order to do a better job. And this is an initiative that's part of Choosing Wisely Canada called STARS, Students and Trainees Advocating for Resource Stewardship. So this is taking folks who are training in medicine to think about resource stewardship seriously. I think, like, if you can come up with an acronym of STARS and you're talking about cutting costs, then I think you've done a fabulous job. So I would endorse the STARS initiative. I'd endorse Choosing Wisely, and I would say let's all embrace this notion of resource stewardship and see it as a shared responsibility that we should all be thinking about and taking forward as part of the work we do. Thank you very much.
You'll be very proud. My family physician back in Edmonton, before I moved here, actually had a Choosing Wisely poster up in her consulting room. And it was partly to help explain why she was not going to prescribe antibiotics every time you had a sneezing fit. All right, so Dean is up. Dean Regier, who is with BC Cancer Agency and also with UBC's Population and Public Health.
I'm always really terrible with these microphones. You can hear me? Yep. So first, thank you so much for the invitation, and thank you for the previous discussions or presentations. I think that my colleagues in this session have done a brilliant job of contextualizing or framing some of the ideas that we kind of struggle through in terms of health economics. And so I guess I'm going to put my talk in a bit of a different space, a bit of a broader space. And so, like, given that we have 7 minutes to try to complete this presentation, I thought I'd give you one idea. The only idea, like, I really want to give you is that we need to look at patient preferences. We need to understand them, incorporate them into economic evaluation, and understand that they are a necessary condition for the efficient allocation of scarce resources. Okay, and what we mean by, there's a few things that I need to unpack here before I kind of go on to the next slide. So preferences are central to economic theory. Okay, and what we mean by preferences is we think that preferences drive decisions or choices. And when we look at how people choose between goods, that choice reveals a value for a specific good. And when you choose one good over another, that incorporates the idea of opportunity cost. Because if you don't choose one good, then you're missing out on that other good's benefit. Okay? And so the difference between those choices, or that choice, indicates opportunity cost and ultimately indicates value. The second part of this that you really need to understand is efficiency and allocation from an economics perspective. We always hear about efficiency, and we always hear about allocation. But what does efficient allocation from the economics perspective mean? And so according to economic theory, efficient allocation means that goods and services should be distributed in a way that maximizes consumer benefit given the costs. Okay, Sterling did a great job with it. We need to look at patients, and we need to look at the cost of technologies. But without that patient perspective, broadly, we can't really compare the utility or the benefit of good according next to its cost. And so why am I going on about this? Is that health economic evaluation, I would suggest, doesn't do a great job of incorporating patient preferences into the economic evaluation of health technologies. So we have this thing called the quality adjusted life here, or quality. Okay, and it's great. It's a brilliant metric because it incorporates length of life gained and multiplies that by a health state. Okay, that health state could be pain, it could be function in terms of can you move about, and the patient in this context says, okay, this is my health state in any given time point. Now, the interesting thing about the utility behind that health state, that's derived from societal preferences, so people without the lived experience of having a specific condition. Now, I'm not saying that societal preferences are important. They're 100% important because they are the largest stakeholder in our publicly funded healthcare system. We also have to understand that patients might actually have a say in terms of the value of the types of health outcomes and non-health outcomes that might come from providing a specific healthcare service. We also have to understand that actually precision medicine or genomics is somewhat about improving health outcomes, and that is very true. But it's actually really about providing information that helps guide decision making. And I think that we need to actually incorporate or broaden our understanding of what provides value or what looks like benefit to realize that this value, there might be value for information beyond the realization or not of a healthcare outcome. For example, in the context of idiopathic intellectual disability, which actually was my PhD topic, I was really enthusiastic about the EQ5D and the Health Utilities Index. And this is the Genome UBC kind of helped fund that, helped fund the implementation of that technology. The problem was that there was no health benefits of giving a child a definitive diagnosis of the cause of their intellectual disability. So the problem, of course, is that under a quality-adjusted life year approach, we shouldn't implement that at all. There is no value to that because it provides a label. Okay? So how do we look at that? How do we, in the context of quality-adjusted life years, we can't really fund that. And so then we came up with this idea of personal utility. Okay? And this is just kind of how we framed it in the genomics literature, saying clinical utility is full stop important. We all agree with that. There's no controversy about that. But actually, in terms of non-health outcomes, it can actually provide, having, for example, in the context of rare diseases and idiopathic intellectual disability, it can help patients understand more about the child or more about labels that actually may or may not have value to it. And so the final thing I kind of want to say is that actually, you can say, okay, Dean, that's great, patients are important. Actually, publics might even be able to say, yeah, we have value for this. But it's complex ideas. And like, can people understand accuracy? Can they understand things like uncertainty, which is a huge aspect of precision medicine, right? Uncertainty around health outcomes, because we don't do a good job of conducting randomized controlled trials in this context of precision medicine. So are patient preferences really like valid in this context? I'm just going to briefly touch on this. So Mohsen said Dean likes to do this thing called choice experiments. And so this is a choice experiment we did in the United States, where we incorporated things like health outcomes, imprecision around health outcomes, medical expert agreement, etc. And we had a large portion of the United States, well, not 1,200 individuals from the United States who had experience with genomics and healthcare to complete this question. And they just answered A, B, or I don't want any information with respect to this. And this is a generic questionnaire. Now the question is, okay, this is kind of a funny thing, but it does incorporate this idea of choice and preference. The question is it useful? So here's how I mapped this out into, I call it 21 gene assays, the Oncotype DX. So we mapped the diffusion over time of Oncotype DX in the United States from 2005 to 2014 using publicly available records. And I took my DCE, which actually had nothing to do with Oncotype DX. It had generic preferences with precision medicine. I said, well, can the DCE predict uptake over time? And we did a pretty good job. It's a blood instrument because it's generic preferences. But my time is up, so I'll just briefly talk about this. So in terms of diffusion over time, we did a pretty good job of tracking diffusion over time. Okay, the correlation was 0.93. You see there are differences even in the smoothing curve that I generated. So the purple line is actual, the blue line is predicted, and the average difference across all these years was around 13%. So just in conclusion, I think that It's absolutely right in terms of quality just like is important, clinical utility is important. But this idea of incorporating patient preferences is essential to economic evaluation, to economics. And also we can actually get, if we do it right, we can actually get pretty reliable preferences that have meaningful prediction power in terms of diffusion and even value. Thank you.
Thank you, Dean. So our final speaker for the afternoon is Carolyn. Here you are. Carolyn from the BC Ministry of Health.
Okay, good afternoon, everyone. I've had an opportunity to talk to a lot of people in the room today, and I picked a topic that I think I heard a lot of interest in yesterday when I had a chance to talk about it very briefly at the Genomics Tropical session on West 18th. Quite enjoyed that. Sorry, I had to cuddle, you know. We've heard a lot today about we need to do separate research from clinical. We need to do economic analysis. We need to do health technology assessment. This is all really important suite of tools for moving precision medicine forward and enabling it. And so what I'm going to do today is talk a bit about point-of-care testing because it is one of the fundamental linchpins for precision medicine. And there's a big regulatory model that sits on top of it. And it's important to understand it, and it's important to respect it, and it's also important for us to think more and more how to enable it. So I'm going to make sure if I'm going the right way here. Which way am I going? This one? Gotta try the mouse. There we go. Okay. Perfect. Thanks. Oh, now it's on? Yeah. Good. So point-of-care testing, if you look it up as an ISO definition through Health Canada or CADIS, some of the national settings, they say it's a diagnostic test performed at or near the site of patients with the result leading to a possible change in the care of the patient. And what I want to say is it's also that kind of a test that has rapid turnaround results. That's creeping in more and more, in a good way. In a good way because it benefits patient care. And so when you think about all those point-of-care tests we've had for a long time, glucose tests, pregnancy tests, anticoagulant tests, we're seeing great benefits from patients for those. But there's a lot more coming on the infectious disease, you know, HIV, influenza, strep A. Those are all developed out of genomics research. We know that in the room, but I have to always educate my colleagues that if there hadn't been genomic research, we wouldn't have a lot of these quick turnaround point-of-care tests. So Health Canada is accrediting more and more of these annually. The level 1 basic medical device, it's very easy to swab, put something in a box, send it away, or get the result right at the patient's site. And that's not a bad thing, but it comes with it needs some oversight. So in BC and Canada, what we see is we have kind of point-of-care testing medical clinical oversight, and that's regulated very closely by lab accreditation. Right? We have a lab accreditation program in the province. We have funding that is only provided to certain public or private labs that are under contract with the government. We have scope of practice regulations under our Health Professions Act that says who gets to diagnose, who gets to prescribe, who gets to work with patients at various levels of the system. We have professional accountability that the colleges have overall. There's 23 health colleges in BC, and they get together regularly and they talk about that health professional accountability. That includes limits and conditions in their bylaws. And we also have, you know, an acute care setting of POCT with quite a broad medical oversight model where we have physicians and pharmacists and nurses. And then we have community settings where the Ministry of Health is working very closely with our partners to put in primary care networks and urgent care centers, which will bring more multidisciplinary teams together and create the medical oversight we need to do more of this, but we're not quite there yet. And outside of the medical clinical systems, we have a lot of direct-to-consumer testing. And we've heard Ancestry.ca, and we've heard 23andMe and various other companies out there that do a lot of this. And a lot of consumers don't understand how their data is being used. They don't understand what's being collected at the point of care, and and they're often maybe not getting the counseling or the results returned them in what would be in an approved or appropriate way. That's not necessarily a bad thing either, because that's innovation, and we learn, everybody's learning as we go, but it's just recognizing that there are different levels of point-of-care testing. Now we're in trouble. Okay. Got it. Make it bigger. So I will talk about, there's lots of opportunities for point-of-care testing, but let's recognize some of the challenges. And I want to thank my co-presenters because you laid them all out very well. You talked about, we're balancing research and innovation with patient safety and quality and appropriateness and effectiveness and privacy. We all want improved outcomes. We all want to measure those outcomes so that we can translate them into new clinical practices. We're developing provincial models to guide decision-making and funding. And new technologies can be a real driver of cost. And we have to recognize that. It's not an infinite bucket of money. And Australia talked about $500 million in genomics funding this year. I mean, that's a big bucket of money. And we don't have something similar in BC, although I will talk about the supercluster and some opportunities there in a second. And then the future provincial precision medicine initiatives, we need transparent POCT policy and processes, because right now there's a lot of confusion between doctors and pharmacists and nurse practitioners and midwives on what these tests are and who gets to use them, and then who gets to return results to our patients. In BC, technically only, and I say only in a just kind of a regulatory way, we have doctors, nurse practitioners, midwives, I think podiatrists that can actually return results to a patient and provide clinical medical support. Pharmacists don't have that scope of practice yet. We're looking at potentially how they fit into the primary care home networks where they will have medical oversight with doctors and whatnot, because we have that in the hospitals already. It's working very well, so it's kind of what can we do in that acute care setting and move it into potentially the community setting so we can benefit patients. But there's still a cost driver there. We don't want just tests being done because we can. And let's be frank, a lot of these tests are already paid for direct by consumer. And so there is going to be a marketplace for that. And so for the province thinking through which tests we'll pay for and which will lead direct to consumer, we have to make some tough decisions there. In the rapidly evolving environment, I've never seen this rate of change. I've been in the health sector for about 11 years, and I've worked through health. I had the health technology assessment program at one point. I ran the provincial databases at one point. I've been on big IT projects. I got lessons learned this long, as I always say, but the rate of technology right now is incredible, and point of care is leading a lot of that. So you're going to see machines in urgent care centers that can test immediately if somebody's got an infectious disease or came in the middle of the night with strep or whatever it is. Like, I think we're going to see real benefits, but we've got to figure out the regulatory framework on top of that to ensure appropriateness and safety and the clinical efficacy of the tests. Now I'm going to try this one more time. Yes. So this is kind of what our regulatory framework looks like right now in BC, and there is a difference between the medical and clinical application side, where we do a lot of point-of-care testing already in a medical setting, and that health and wellness direct-to-consumer side. We can't possibly keep up with all the technology and tests out there, so it's up to the consumer to decide if they want to participate in something or if they want to use a test. And I think they should have a choice. But in that little, the Venn diagram in the middle, where we see selected testing that requires further regulation, that's where we're going to spend our time really thinking through, okay, what's the value add there? And when are things crossing from direct-to-consumer really into the clinical side of things? Because when a test starts to do that, we should pay more attention to it and put more evaluation around it. And then we should provide advice back to our practitioners on how to use it and how to return results, store results, and work with the patient over the longer term. So we're doing that work right now with the BC College Health Regulators. We've got some working groups, and we're thinking through what do we that gray area. What's in that gray area? How do we enable it where it makes sense? And where do we send out some very better direction on, I think I'm praying up here, somebody's taking pictures, I've got my hands together, but we're really sorting through what to do there. And I will say just one thing. The BC Supercluster, very exciting times. I think we're going to have some very interesting discussions on pharmacogenomics, which technically is a point of care test, and how those results are collected, how their results are returned to the patients, how they get into a health record. Those are going to be some big questions that we want to look at, but very exciting that that's one that's